Thank you for joining today's Flex Program Telehealth webinar series, Virtual Primary Care. By attending this webinar, participants will be able to define what virtual primary care is and what a visit looks like for a patient, recall data and evidence related to the effectiveness of virtual primary care, identify the opportunities and challenges of virtual primary care for rural health providers, describe how COVID is affecting and may affect virtual primary care as a service line, recognize new non-traditional competitors to rural hospitals using virtual health services, as well as give examples of flex programs to support telehealth efforts in rural hospitals and clinics. With all of that being shared, I'd like to welcome Nicole Clement today from the center, who will kick us off in today's event.
Thanks, Kiona. Hi, everybody. Thanks for joining us. Like Kiona said, this is the third webinar of the telehealth webinar series that we've been working on this program year. We have 3 more webinars coming up, and also a few other upcoming TASC events. We have, I just changed the date on that. June Flex Virtual Knowledge Group should be June 17th, not June 10th. I changed that because I was thinking it was supposed to be the MB Quick Virtual Knowledge Group. So June Flex Virtual Knowledge Group, June 15th. We'll send out clarification on that or put it in the chat because now I've got it all confused. My apologies. We'll put both those dates in the chat. We have a webinar coming up on June 16th at 2 p.m. Central Time to share the findings of the Rural Community Paramedicine Summit that we had at the end of February. So that'll be about implementing and sustaining rural community paramedicine. Our next webinar in this telehealth webinar series is Tele-Monitoring of rural patients. That will be July 7th at 2 p.m. Central Time. And then in July, the afternoons of the 20th through the 22nd, we'll have the Flex Program Virtual Reverse Site Visit. One more announcement that we have before we go ahead and introduce our speakers and kick this thing off. We have a brand new resource. A topic collection is now available on our website. This one is telehealth, so click on that link and you can view important rural relevant resources related to telehealth. We'll be sending out some further communication about this, but this is specifically tailored to rural telehealth, and it is added to and reviewed often, so will always be relevant. We do have some other topic collections on our website as well that you have probably encountered because a lot of them have been around a long time, and the same is true. They are reviewed regularly and have additions and edits made to them. So COVID-19, HIT, EMS, there's all kinds of those. So that link is there as well. So I'm going to stop sharing my screen and introduce our speaker. You can go ahead and share your screen whenever you're ready, Elizabeth. So our speaker today is Dr. Elizabeth Krapinski. She's a professor and vice chair for research at Emory University in the Department of Radiology and Imaging Sciences. She received her BA from Cornell, MA from Montclair State, and PhD from Temple, all in experimental psychology. Her interests are in medical image perception, observer performance, decision-making, and human factors. She is Associate Director of Evaluation for the Arizona Telemedicine Program and co-director of the Southwest Telehealth Resource Center. She is past president of the American Telehealth Association, past chair of Society for Imaging Informatics in Medicine, past chair of the SPIE Medical Imaging Conference, and president of the Medical Image Perception Society. So there is a little bit more, but I think with that, I'm going to just go ahead and turn it over to you and let you start talking to us about virtual primary care.
All right, thank you very much for that warm introduction. And I think it's safe to say good afternoon to everyone. So yeah, I'm going to talk about virtual primary care. And the learning objectives were already stated, so I don't have to go over that. I also don't have any significant disclosures. So I'm just going to dig right into it and give you a whirlwind tour of some of those topics. So basically, what is telemedicine, telehealth, virtual care, e-health, m-health? I mean, there's a lot of terms out there. What it boils down to is that it's the use of electronic information and basically just telecommunications technologies that are going to support long distance, and sometimes it's actually kind of short distance. I've seen some programs that are literally around the block. Clinical healthcare, patient and professional health related education, public health, health administration, basically utilizing, like I said, telecommunications technologies, video conferencing, internet, photographs being sent back and forth, streaming media, and any kind of telecommunications device, whether it's phones, laptops, iPads, satellite, however you connect. Telehealth, you might have heard, is a broader term than the previous one, which was telemedicine. And it is just the broader scope of health services overall, including non-clinical services, such as training, administrative meetings, CME, in addition to the clinical services. Virtual healthcare is typically synonymous with telemedicine. mHealth is specifically with mobile devices, iPads, telephones, and so on. Electronic health typically refers to just like email. There's other terms out there, connected health and so on. But like I said, what it comes down to is simply utilizing a variety of technologies out there to enable patients to connect with their providers over long distances and or short distances. Like I said, sometimes in very urban settings, it can be literally around the corner. It encompasses all clinical specialties. I honestly don't think there's a clinical specialty that cannot be done to some degree via telemedicine. These are examples of sort of the store and forward or the picture-based technologies. There's ophthalmology, dermatology, pathology, radiology, ENT. Whatever you can do to acquire an image can be done via telemedicine. There are even apps on your phone that parents can download that literally will allow you to capture images of your child's eardrum, for example, if they are suspicious of having an ear infection. And some of these are actually pretty good. There are apps that you can download to acquire digital images of skin for dermatology. And there's actually some for ophthalmology for home use as well. So just a lot of capability out there with image-based technologies to acquire health information to give to providers. There's also a lot of audio-based ones. For example, using the electronic stethoscope, you can get heart and lung sounds, and they're really quite reliable. And a lot of providers that I know say they prefer electronic stethoscopes overall, just in person, because they are just far more sensitive, far more accurate. And you can slap some AI on top of these artificial intelligence schemes that will actually help interpret some of these heart and lung sounds, often at least as good as, or sometimes better than, experts in the field. You can do speech and language therapy. You can do music therapy. You can do all sorts of things that are sound-based, utilizing telemedicine technologies. And then there's also sort of some of the more traditional ones, I guess, where there's just talking back and forth between the provider and the patients, telepsychiatry, psychology, group counseling, and a lot of different clinical specialties. This is sort of the most common type of telemedicine that's being conducted. There's also sort of the, you can do telestroke with this, send some images, doing store and forward to get your CT of the head, and then a neurologist could log in to see the patient in the ICU or the emergency room and do a different type of exam in a virtual sense. There's the tele-ICU, which is telemedicine as well, but it's a lot of remote patient monitoring of patients who are, for example, in different ICUs. And you can get really funky, and you can actually do surgery remotely using, for example, the Da Vinci robot. But there's a lot you can do. It extends out to teledentistry, all sorts of clinical and counseling as well. You can do group therapy sessions. You can do cancer support groups. You can do tele-rehab. There's just, like I said, practically any clinical specialty is amenable to some degree to doing it virtually. So it really does encompass just about everything. You can go into the patient's home, and you can do an awful lot directly into the patient's home. For example, checking on the patient's colostomy or urostomy, checking on post-surgery recovery and so on. You can do, like I said, tele-rehab into the patient's home and all sorts of stuff as well. So the setting these days really doesn't matter as much as it used to. There's also a considerable amount of wearable and usable devices that are available to providers to prescribe to patients that will collect data on different states and automatically upload information into the electronic health record. Again, assuming that you have this set up and you're arranged for it. But there's also tools that you can provide to the patient that they can then upload, in email perhaps to you. Some of these are FDA approved for actual clinical use, for example, EKG harnesses and so on. But there's a lot of tools out there that patients can simply get on their own to track their physiological signs and so on. So for example, smartwatches, there's a lot of apps out there to track your mood. These are really great for helping patients with mental and behavioral issues. There's all sorts of sensors that are embedded in cars and houses on your body. There are smart socks that you can prescribe to diabetic patients that will keep track of what's happening in their feet and whether ulcers are developing and so on. Things that patients can swallow that can track the status of their gut and literally, again, just upload via Bluetooth connections to get information. So all of this falls under the rubric of telemedicine and or virtual health, however you want to look at it. And like I said, I think every clinical specialty is amenable to telemedicine. Well, now what happened during COVID? Essentially it just exploded. It became the way to interact with patients in clinical specialties, primary care especially. There's certain things that can't be done, and there's an instance where the patient still has to be seen in person. And to be perfectly honest, I think telemedicine greatly benefited from COVID. It's kind of a sad thing to say, but ironically, it's true. And not only did it take off, but we learned an awful lot about what is feasible and what isn't feasible. So if you look at who are the users of telehealth, frontline providers, but primary care physicians were heavy use. 97% of primary care providers said they were using and are still using virtual health, telehealth during the COVID crisis. And some of the numbers down here in the lower left, as you can see, starting back in last June through last June up until about last March, right here on the convergence, you could see that, telehealth was a little bit used, and then COVID hit, and then boom, all of a sudden telehealth increases, in-person totally decreased, and it kind of plateaued off. There was a huge peak last March, April, May, June, and then it did start to go down as people started to develop hybrid services and some clinics and stuff started to open up. But it has leveled off at a higher level, far higher level than it was pre-COVID. And overall, it's expected to continue on a trajectory of this plateau and then probably increasing as well as we go into hybrid models. But in terms of worldwide dollars and what's going to be global revenue, it's just projected to keep increasing. And a lot of this was brought out by necessity, but also by waivers and easing of restrictions from the federal government, from CMS, opportunities from the FCC in terms of offering funds for broadband and so on. There's another opportunity now for providers and patients actually to get funds for broadband access. But a lot of the restrictions during COVID included things like waiving or relaxation of HIPAA requirements, relaxation of interstate licensure requirements and the ability to go over lines, relaxation of prescribing guidelines, and numerous codes, billing codes that were opened up. Now, what's going to happen after COVID? Who knows? But those of us who are kind of in the field are convinced that a good number of the waivers and the relaxation of the rules are going to stay in place. Some are going to go back. HIPAA Obviously, we're not going to be able to continue to use non-HIPAA compliant devices for telemedicine. Prescribing is going to come back a bit. You're obviously no longer going to be able to prescribe some of the stronger medications, opioids, and so on. Interstate licensure is eased up. It already is, or go back. It already is going back for a number of states. A lot of the billing codes, however, are going to stay in place, as well as we think a lot of the relaxation in terms of where the providers and the patients had to be, and the types of things that are going to be allowed. A big question that I always get is telephone still going to be allowed? That's a hard one to tell. And it's split 50-50 really on people who believe it's going to still be allowed and those who say, no way, it's not going to be allowed anymore. But every time the emergency gets extended, so do the waivers. And so we're just going to have to be in a wait and see. But I am firmly convinced that telemedicine will remain in practically every practice in some form or another. And a lot of people are going to have to adapt to a sort of a hybrid version of their practices afterwards. And the reason why is, patients simply are going to want it. Once they figured out that they don't have to drive an hour, find a parking space, go sit in a lobby for a half an hour with a bunch of other sick people, see their provider for 15 minutes, get the prescription or whatever that they needed, and then repeat that whole process while taking time from work, taking time from school, and so on. A lot of things can be done virtually, and a lot of patients and providers like it and appreciate the fact that an awful lot can be done. However, like I said before, we also learned that there are certain things that you cannot really accomplish virtually, and that there are certain things that patients prefer to come in person. And there's a subset of patients that prefer to come in person no matter what. And it's not a particular demographic. Some people say, oh, well, that's just everybody over 45 that wants to come in. It's absolutely not true. Different demographics, different people have their own preferences, and you really can't pigeonhole or categorize those who are interested in telemedicine versus not, simply based on, kind of biased preconceptions of who's willing to use their computers or not. One of the objectives was to, notice and be aware of the fact that there's these non-traditional folks coming into play. And these are just some of the headlines from the news. Walmart, Teams, Amazon, Minute Clinics, that's CVS, Publix, grocery stores, Google Health, Walgreens, anybody and everybody is getting into the telehealth arena, whether it's in terms of providing platforms, providers, or simply providing a place where people can go to these kiosks. And it is not going to go away. These are big companies, and they have found that people want easy access to healthcare. And they have found that there are providers out there willing to work in their networks and provide that care. And patients are willing, more than you would think, to simply log on, swipe their credit card for $49.99 or whatever, and access a provider, in all likelihood who they've never met before, to get answers to their questions in a timely fashion. So it's out there. There are some, obviously they have to play by the same rules as everybody else, but it is a huge market, and these companies are going to revolutionize healthcare. Amazon Care, who would have thought, but it's out there. Microsoft is in this, Google is in this, all the big companies are in this that people are familiar with. They know their names. They don't have to go out and create a brand name. They're out there, and they are competition for a lot of things. It's going to be interesting to see how it evolves into the future. And as I said, patients are more than willing in many circumstances to go and engage in virtual health. This was a survey that was done during COVID, looking at, what are patients comfortable asking, or what types of conditions would they seek telemedicine treatment for? And they're not surprising. Ears, nose, and throat, routine preventive visits, and mental health and behavioral therapy are the top three. And these we see being used, I mean, it's been exponential what people have experienced. There's some things that people are less willing, and there are some things, luckily, that they aren't. I can't tell if it's cut off on your screen as well. Unfortunately, is on mine. But that bottom line is physical and rehabilitational therapy, respiratory, urgent care, pediatric, heart-related. Thank goodness people are still willing to call 911 when they think they're having a heart attack. And not surprisingly, oral and dental, people are still not quite convinced that that's actually going to work. What's going to help people decide whether they're going to make a telemedicine appointment? These do not surprise me at all. One, it's got to be easy. Send me a link, click. I don't want to have to download anything. I don't want to have to figure out anything. I just want to be able to click. They also want to be told that they're available. So those of you who are looking to do telemedicine, get more involved, you actually have to offer it to your patients as an option. Maybe get a little marketing campaign going on. Patients also want online scheduling options. They don't want to talk to somebody. They don't want a scheduler. Oh, this one's available. So just go online, click, click, click. I'll be there. And they also want it available now. I'm not sure if this is every generation or just the current generation who's like the instantaneous gratification, but people want their appointments and they want to be seen now. Interestingly, they're not always all that interested in finding out if their insurance covers telemedicine, which kind of surprised me. Less and less people are caring about having a secure platform. They just want to be connected. They want everybody else to like them. So if you've got 5-star ratings for your telemedicine service, you're probably going to get the customers, while somebody with 3-star ratings is not going to get the same services that you are. People kind of like that 5-star rating, no matter what it's applied to, even their healthcare. If you're looking for guidance on what to do and how to do it, I recommend this document. You can email me if you can't get a copy of it. It's a document we put out a number of years ago, 6 years ago, on practice guidelines for live and on-demand primary and urgent care by the American Telemedicine Association. This was created by a group of experts, and you can see what it includes there. It's got practice guidelines, technical guidelines, and administrative. It is still highly relevant and a lot of good tips. And there's a really good reference section at the end. So if you're looking for evidence on, can you use telemedicine for primary care? Absolutely, you can. And speaking of the evidence, there's well over 25 years worth of evidence. There's 2 key journals that have been out there that long: Journal of Telemedicine and Telecare, and the Telemedicine and eHealth Journal are the 2 main ones. Both of them have been around for 25 years, and both of them have a wealth of information. I mean, the preponderance of information says telemedicine works. Yes, there are circumstances where it doesn't. Yes, it has to be done right. But that's the same with any clinical practice and any specialty. So there is a lot of evidence out there on the benefits of telehealth. You have to, in my opinion, decide what it is you want to do and accomplish with telemedicine. It all depends on what your metrics are. Simply saying we're going to do telemedicine because it's popular, that's a dumb reason for doing it. We're going to do telemedicine to reduce our no-show rates. We're going to do telemedicine to improve the outcomes of our patients in XXX. That's the way to approach telemedicine and deciding if it works. Not, we just want to do it and we want to see if it works, or not because we want to increase our profit margin. Those are all the wrong reasons to do telemedicine. But if you have specific goals in mind, specific metrics, and ways that you're going to measure and accomplish that, I think telemedicine can be very successful. And like I said, the evidence base for it is very strong. Now, this is part of that document that unfortunately never did not get put into the document. And again, I can give you copies of it. But what we did was we set up 3 categories. One is routine conditions that are appropriate for telemedicine, and we split it out into video versus telephone only. And then up here on the right, there's conditions that may be appropriate for telemedicine management. Again, video versus telephone. And again, this depends on the provider's experience, the type of patient, and so on. And then conditions that are not appropriate for telemedicine management, things like chest pain, acute chronic shortness of breath. This is a very useful table, in my opinion, for all providers, but especially primary care providers, to kind of decide, well, depending on what the patient kind of emailed you, what they think their symptoms are, what they're experiencing, how you can kind of triage them to telemedicine or not. Annual wellness visits can be done by telemedicine, and I think it allows you to engage proactively with your patients. You can meet their care needs before they become acute enough to require in-person visits. It can help identify and get counseling on risky behaviors. And you can also utilize it to reschedule and remind about screening exam. Now, obviously, for the screening part, they're going to have to come in. You can't get your x-rays and you cannot get your labs virtually. Not yet, but I'm sure at some point in time we will. Care teams can interact with their patients who might, for example, benefit from chronic care management. And you simply have to, document what you're doing and what the limitations of your visit were. And professional judgment and experience outweighs everything. It's like in person. Common sense and your skills, your expertise, the art and the science of providing care is what you rely on in the virtual environment as you would in the in-person environment. You can do it with pediatrics as well, and you can do all the same things. And there are guidelines out there from relevant societies on, carrying out these well visits with patients, both adults and peds. These are just some of the tools that are out there. And again, I have access to them if you can't find them. These are just basically 3 easy, quick and dirty checklists, I guess, on how to conduct a virtual physical exam. That is, part and parcel to any primary care provider. And some things you can do and some things you can't, but you've got standard things that you do during an exam. And a lot of those can be replicated or at least amenable to virtual care. Again, you may need the patient to help you or a caregiver of the patient to help you get the information. And at some point, you may have to say to a particular patient, I'm going to have to see you in person. Again, a lot depends on the patient's capabilities and the nature of the condition and what you're trying to diagnose. There's a really good article, the Telehealth 10. It's a guide for patient-assisted virtual physical examination. And that's a really good article. It came out in the American Journal of Medicine earlier this year. Really great. It provides that 10-step process up here on the upper right on, how to conduct some of the main things in a virtual physical exam. So there is a lot of guidance out there. The AAMC recently came out with a set of 6 telehealth competencies that they are actively promoting to start to get medical schools to consider. But they also have this sort of 3 stages of your career. One, as you're kind of going from medical student into residency. The second stage, and the competencies increase in complexity and responsibility as you're going from residency into practice. And then 3 to 5 years out there in practice. And I don't want to go through them all, but these are the 6 domains. And within each domain, there's sets of usually 3 to 5 different competencies that they expect people to have. You can download it for free from the AAMC website. If you just Google AAMC Telehealth, you'll go straight to their page. It'll say you're going to go to a cart, put it in your cart, but it's absolutely free. You can download it. Great document, and it covers things like patient safety and appropriate use of telehealth, access and equity, communication. It's just not the easiest thing in the world for some people to get on. And how do you communicate with patients? How do you establish rapport virtually with a patient? I got a whole nother talk on that. They expect you to know a little bit about technology. They don't want you to be an engineer, ethical practices, legal requirements. And like I said, it's a free download, great document. And that really is, I think, what's going to guide a lot of the future of telemedicine. If you're looking for help on setting up your practice, getting things going, I highly recommend the National Consortium of Telehealth Resource Centers. We are a group of 14 HRSA funded, so we are federally funded by the federal government to provide assistance in setting up, maintaining, establishing, growing your telemedicine programs. 12 of us are regional, and as you can see on the map, these are the 12 regions. We cover the United States. Every single state is covered. You can go to our website and simply click on your state, and you will be taken directly to your telehealth resource center. Those are all our little acronyms. So there's like, California Telehealth, there's the Pacific Basin, we're the Southwest. And our services for the most part are free, up until about 10 hours worth of help, but a lot of your questions can be readily answered quite often just by email. A lot of the questions we have, for example, are about billing, about legal, what's going to happen after COVID, stuff like that. But we all do training on telemedicine. We all host webinars, and we all have a lot of resources for providers and patients to do telehealth. We have, for example, HIPAA flyers. What is HIPAA all about? The Southwest Telehealth Resource Center, in particular, we have documents translated into Spanish and Navajo because that's what's common to our regions. Some of the other sites have them translated into other languages as well. So please, if you have questions, you need help with your telemedicine program, please reach out to your Telehealth Resource Center. I said there were 12 regional ones, but we also have 2 national level ones. There's the Center for Connected Health Policy. They know anything and everything about policy, about what each individual state covers, what they don't cover. And they twice a year provide a 50-state document summarizing all the sort of the statutes. Do they do cross-state licensure? What's their Medicaid rules or Medicaid rules and so on. So great document. I can get you that as well. Then there's TTAC. If you have technology questions, what platforms are out there, which ones are, what do they provide? They're not going to tell you which ones to buy. They're not going to tell you which one is better or the best out there. They will provide you, however, with information about what each one is capable of and allow you to render your own decision about what you should adopt. So telemedicine is here to stay, and it's going to impact just about everybody involved in patient care, not just providers, but everybody in your organization, your billing folks, your scheduling folks, your IT folks, your administration, literally everybody, and the broader community as a whole. Patients are out there and they really do like it. Some of the waivers, the codes, the expansions that we got successfully pushed through during COVID are going to remain. Some of them are going to sunset, but we'll find out once the public health emergency is over how all this shakes out. But like I said, I'm pretty convinced a lot of it's going to stay in terms of the billing codes and the sites where the provider and the patients can be. Every specialty to some degree is using telemedicine, and they will continue to do so. It requires a certain amount of infrastructure, enthusiasm, support to effectively and efficiently deliver quality healthcare virtually, but it can be done. I think we need to start training our future workforce really on how to truly fully realize the full potential of telemedicine and to truly integrate it seamlessly into our healthcare systems, our homes, our lives. I think that's going to be the bigger challenge once we're out of COVID, is how do we develop a hybrid way of providing in-person and telehealth services in an effective and seamless manner? How do we integrate this into our electronic health records, into our patient portals if we have them? And if we don't, how do we in the future create systems where it is completely integrated? So I thank you very much. I know it's a lot of information in a half an hour, but hopefully it'll give you something to think about and questions to ask. So thank you.
Thank you, Dr. Krupinski. Did anybody have any questions for her? Okay, hearing none, you can always put them in the chat as well. But to kind of give their experience of some of the things that she was just talking about convincing and having some enthusiasm and that sort of thing. Steve Barnett is going to talk for just a few minutes about what his experience has been kind of living through this telehealth boom. So Steve is the president and CEO of Mackenzie Health System in Michigan. And like I said, he's going to tell us what his experience has been with virtual primary care for the last bunch of years and where they're at right now with it.
thanks, Nicole. Can you hear me okay?
Yeah, absolutely.
As luck would have it, I'm having trouble with connectivity today during this webinar. So I guess that speaks to the very foundation of what can go wrong when you're trying to develop a program that really can reach a lot of people that we typically have not been able to reach. Pre-COVID, you know, from a virtual primary care point of view, our main experience was provider resistance to virtual visits, even though virtual activity was on the rise, from the consumer that sits on their sofa and accesses it from home, or those that are going into some form, variety of high urgent care types of facilities that may be also using a platform to access a primary care provider. We were able to open during that pre-COVID time an after-hours clinic, as a matter of fact, that required a patient to come in to a location. Unfortunately, we'd have MAs there, and they would room the patient, get some initial information, and then bring our nurse practitioner online to actually do the visit. And that was pretty well received by our community, which, like many communities, is one that, you know, has a demographic that favors an older population rather than a younger population, and a Medicaid population versus a commercial payer population. So once COVID hit in March of 2020, we saw visits drop across all clinics, including that clinic that was functioning as a quasi-hybrid telemedicine clinic. Under the public health emergency, both federal and state waivers were put in place. You've already heard a lot about that quickly, and virtual visit revenue was adjusted to reflect the work being done. Like the previous speaker, I'm optimistic that we'll see that those waivers continue into the future and not dampen one's enthusiasm that's built during COVID to actually begin to embrace telemedicine. Because provider volume was low, concerns began to rise regarding those patients who may need med adjustments or close monitoring because of their chronic conditions, and them just not coming in. So it took a resistant provider group and really fast forwarded them into some form of telemedicine, even if it was just telephone visits. But it gave them a lot to think about, and I think a lot of reconsideration about the value of virtual visits was a benefit from COVID over the last year and a half. On the value side of virtual primary care, my hopes beyond the public health emergency, we all hope that the waivers will be permanent, or many of them will be. I suspect provider resistance is no longer going to be an issue. The question now is how we accelerate the adoption of virtual techniques and expand upon that platform. We know that there are generational differences, and we know that in rural America, bandwidth infrastructure is still not in place. I think that was also addressed. In my view, we should be treating bandwidth infrastructure build out as a utility that's necessary, not something that's nice to have. And until we see that kind of an investment, we're going to have this sort of spotty connectivity that many of the rural residents that we want to have access telemedicine won't be able to do so. I did send you, Nicole, a couple of items. One is a bill that was introduced in Michigan. It was part of a health reform 15 bill package in our state capitol. It was introduced by the Senate and House Majority Leader in Michigan. And one of the bills in that 15 bill pack it had trouble passing. It was all introduced on the House side, and everything except for this one, which dealt with telemedicine, passed broadly to go on to the Senate. But this one lingered in the House for a little while, and it was beginning to wonder if it would even make it out of the House and be part of the packet going over to the Senate. It did, but by a very slim margin. So what that tells me is that A, there was a lot of confusion, or B, it was poorly written, or C, there's a whole lot of amendments that are going to come back out of the Senate that are attached to that telemedicine bill. One of the things that we've been doing to assess what the opportunity is from a Michigan Hospital Association standpoint is to look across the country and see what is going on right now. And I'd pass that also on to you. I think it's a nice summary, Nicole, that, obviously any member of this audience is free to take a look at, but it will tell you that all states took advantage under the public health emergency, that easement and licensure policy, physician nursing compacts and all the like. And what we showed that all the states did embrace that ease and licensure policy. There wasn't one that didn't. But on the compact issue, we found that 23 states did both, 9 did none, and 11 did nursing only, and 7 only acknowledged physicians in interstate compacts. The other thing that is on that summary that you'll see is there were no states out-of-state telemedicine providers in without oversight. And then 36 states have no special licensure for out-of-state providers, 10 do, and 4 have pending legislation. And then on that summary, you'll also see a column that really, I think, gives you a pretty good analysis of what's going on legislatively across the country. And clearly, there's a lot of activity about how do we control and make sure that the level of care that's being delivered is there and aligned with the level of care that the state is seeking to control. And then one last thing that I thought might be of interest is a ckley report dated May 10th, 2021. And I thought this was telling, and I think your speaker also addressed some of these pieces as well. Telehealth is a disruptor sector. It expands across and convenience, or access and convenience. Though some providers say it adds cost and unnecessary services, most think telehealth savings can be significant if integrated in care management effectively and geographic restrictions are lifted. And if you notice, those are things that are being touched by that summary document on state activity. It came of age during the pandemic, and now it's seen as a vital element in bricks and clicks strategies for healthcare. While attention to the Walmart MD deal will focus on its expanded telehealth focus and positioning vis-a-vis Amazon Care, the bigger story is this: the U.S. health industry is at a crossroad. Healthcare delivery is decreasingly controlled by hospitals and physicians, and healthcare financing is no longer dominated by traditional insurers and employer-funded benefits. What mega players like Walmart, CVS, Walgreens, Boots, Alliance, Amazon, United Health, and others response seems aligned with the bet that patients will behave as consumers and be treated as customers. Services are convenient and readily accessible, and surprise medical bills and sticker shock become relics of the past. So this deal symbolizes the widening gap between healthcare's future and its past. Walmart aspires to be a major player in healthcare's future. And I think that really says and underscores the point already made, and that is telehealth's not going anywhere, but we certainly need the infrastructure to support it if we're going to begin to shift and depend on it. So leave it there, Nicole.
Thanks. I think the point you bring up is really huge. Telehealth used to be about providing access to specialists, right, for rural hospitals, and it isn't that anymore. There's the big players, the Amazons and CVS and Walmart, that are swooping in and wanting to add clinics to, make them really easy and accessible. And what does that do for the market share of the small hospitals and clinics and that sort of thing? And another point too, Dr. Kopinski put a link to a bill for Arizona for expanding telehealth. You talked about the one for Michigan. every single state probably has something going on, and whatever that is in that state really is going to have a lot to do with what telehealth looks like after the public health emergency. And so to that point, I also have one more person to share some information with us. Rose Locklear from the Oregon State Office of Rural Health is going to talk to us a little bit about what's going on in Oregon. And her and I had kind of a lengthy conversation about, you know, the feds are one thing, but what's happening in a state is another thing. So Rose is also going to talk about a really interesting project that she has going on that is almost ready to be shared, and I'm super excited to see that. So Rose, I'll turn it over to you.
All right, well, thank you, Nicole. And yeah, I will just really be echoing a lot of what's been said, but from the State Office of Rural Health perspective, and specifically talking about some of the work that we've done recently, looking at our rural health clinics, right? Dr. Krupinski was talking pretty extensively about the utilization of telehealth for primary care. And with the expansion of the RHCs being able to bill as a distance site this past year under the public health emergency, we really wanted to take a look and see exactly what they were doing, and had a really unique opportunity to do so by way of some funding that was disseminated to Oregon from the Telehealth Resource Center that serves us, which is the Northwest Regional Telehealth Resource Center. So Nicole asked me to share, you know, how as a State Office of Rural Health, we support telehealth and how we support our clinics. And, you know, as offices of rural health, we're tasked with information dissemination. And since we work pretty intimately with our Telehealth Resource Center, that is I serve on their board. So actively participate in their virtual learning opportunities and share and disseminate that information out to our clinics and hospitals. Policy coming from the Center for Connected Health Policy. As mentioned earlier, there's the TTAC, the National Telehealth Technology Assessment Resource Center, an amazing opportunity to connect clinics or hospitals that are interested in getting a telehealth program up and running, but they're only reaching out to vendors. So this is really an agnostic way to connect folks to quality information around technology. And then this past year, having received that sub-award from the Northwest Telehealth Resource Center from the CARES Act, that actually went to our Telehealth Alliance of Oregon. And as board members of the Telehealth Alliance of Oregon, we decided to collect information looking at our rural health clinics, because as we all know, there's going to be a lot of conversation, and already has been a lot of conversation in the policy realm of things as far as what are these folks doing? Were they doing it before? Do they want to continue to offer it? What are the common sorts of conditions that they're able to do telehealth for? So as Nicole mentioned, I created a ArcGIS story map to catalog and visualize this information. And we will share it a little bit later this week out broadly, but information at connects is organized by county, really shares the services that each of the clinics that responded. I reached out by telephone and had a conversation with about 80 of our 102 rural health clinics. So we captured some really great information coming from them, a lot of primary care services, virtual medication management, follow-up, behavioral health, some specialty services. And so for the majority of the primary care services, one of the data points that I captured was the implementation date. And we really saw across the board that the implementation date was somewhere in the early spring of 2020, last year, when we all went into this public health emergency. So it was once, you know, the federal government opened up that expansion, allowing them to be distant site, the majority hopped on board and took advantage of that. As well as the implementation date, I also wanted to get you know, do you plan to continue to offer this past the public health emergency? Collect that data point across the board. And the overwhelming response was yes. And there were certainly some common challenges shared, and that yes, past the public health emergency was definitely articulated with the caveat of, you know, if we're able to continue to be reimbursed and hit our bottom line, you know, and especially for some of the smaller independent clinics, it really does take just as much time as an in-person visit in order to get folks set up, get them comfortable with the technology, get their providers comfortable with the technology. So there certainly was a cultural shift that had to occur in order to get this done. So I will leave you with some of the common challenges that were identified. I think that one of the pieces that I wanted to be able to articulate at the state level and even beyond was, we heard a lot about broadband, but really, is that the only challenge that you all are experiencing out there? And there was so much more to it. And patient connectivity, access to broadband, but also access to a two-way audio video device. When it came down to technology, there's a literacy component, user error, the cultural shift to acceptance by both providers and patients. And Dr. Kopinski shared some resources earlier, and those are the sorts of things that the telehealth resource centers can help with. Some of the information for providers, information for patients. Moreover, challenges with regard to vision, dexterity, inability to see and navigate a screen and keys, and really finding a telehealth platform, as mentioned earlier, that is easy to use by both the patient and provider. Again, that reimbursement being key, the ability to continue past the PHE as a distant site, and then finally, parity or and then a barrier being a really low audio only rate. And then finally, an interesting one that I think is especially important for things like behavioral health is patient privacy. You're no longer behind a closed door of a clinic office, and that is a challenge or a barrier to navigate through. So I'll stop there and certainly share this resource out largely with you all this week. Thank you.
Thank you, Rose. Great information. I can't wait to see what that map looks like. I think that'll be something that could be really of interest to other flex programs, as I've heard flex programs talking about needs assessment and kind of how to figure out exactly what they could help with. I mean, we all know what the traditional roles of flex programs are, right? Providing support and education, planning, implementing, and demonstration projects and those sorts of things. But telehealth, it just has really changed so much in the last year that figuring out exactly where to start with that is, and what's already happening in your state, whatever you might have known, you don't know now. Like that could look vastly different than what it looked like a year ago. So those are all things to think about. And I think the project that you're discussing, that you're talking about and going to share with us later in the week, that could be kind of an interesting way of approaching that. Kiona's going to go ahead and put up some polling questions, some exiting polling questions as we are kind of wrapping things up here. Thank you so much, Dr. Kopinski, for your time today. I think your presentation was fantastic. It included everything I asked for. It was really, really great. Thank you, Steve, and thank you, Rose, both for joining us and sharing what your experiences have been. One other event I forgot to share earlier when I was just kicking us off is, and it hasn't been sent out to you all yet, but will be soon, June 17th at 2 p.m. Central Time. There will be another Rural HIT Coalition call. We met this morning and started doing some planning on what the topic of that is going to be. There's always an educational topic. There will be, as always, federal and legislative updates, regulatory updates, an update from the Federal Office of Rural Health Policy and the Office for the Advancement of Telehealth, and then also a little bit of time at the end after the educational part to have a discussion about whatever you guys all want to talk about. So June 17th at 2 p.m. Central Time, and we will send out a calendar appointment about that soon. So with that, again, please take a minute to just fill out these polling questions, and that's really it, unless anybody has any questions they want to throw out there while we have 2 or 3 minutes left to talk. Yeah, I will email you about those documents, Dr. Kopinski, so we make sure we get those and can share them with the participants when we share out the recording. The one ATA one, it looked like I had to have access to their website, so I got an email. I'm not sure what exactly
I'll,
that
I'll,
says
I'll,
yet.
email- I'll just email it to you. I get it
Okay,
for
I
free.
started trying to track it down, but it wasn't just an easy link. So,
No, no way. I'll get it to you.
okay, that'd be great. And then some of these other things too, the Center for Connected Health Policy and that sort of thing that I didn't paste links in, but I know where those things are, so. Okay, well, I think we will call this good since I'm not hearing any questions. Thank you, everybody, for joining us today and have a great day.
Thank you.
Thanks.
Thank you.
Thanks. Have a good day.
Yep. Bye.
Thanks all. Thanks, Elizabeth. In this one, Sika